Yeah, ladies and gentlemen, dear colleagues, that's the last session in this room. It's a rapid fire session. We have 55 minutes for 56 minutes of talk. So it has to be rapid, and we have to light the room up. It's the last session in this room. We really can set it on fire. And the first one is done by Dr. Erika Meyer from the Dana-Farber Cancer Institute. And we're going to hear data from the TBCRC 056 study about a combination of PARP inhibitor and immune checkpoint inhibitor. Erika.
Thank you so much. On behalf of my co-authors, I'd like to thank the organizers for inviting us to present results from the ER-positive cohort of TBCRC 056. These are my disclosures. PARP inhibitors have an approved role in the management of germline BRCA-mutated breast cancer. When used as monotherapy in the preoperative setting for predominantly triple-negative breast cancer, PATCR rates approach 50%. Preclinical data suggests synergy between PARP inhibitors and immunotherapy. Exposure to PARP inhibitors lead to activation of the cGAS-STING pathway, T-cell recruitment, thus sensitizing germline BRCA-mutated cancers to immunotherapy. TBCRC 056 was designed to evaluate the combination of a PARP inhibitor, niraparib, with an anti-PD-1 antibody, dostarlimab, in the neoadjuvant treatment of germline BRCA1/2 PALB2 mutated HER2-negative breast cancer. TBCRC 056 is a prospective phase 2 multicenter trial with 3 arms. 2 of the arms are for triple-negative breast cancer. We are going to discuss Arm C, an exploratory cohort for ER-positive disease defined as 10% or more. Eligible patients had stage 1 to 3 breast cancer with a tumor size of 1 centimeter or more, HER2 negative, and a germline mutation. Therapy consisted of 18 weeks of combination niraparib and dostarlimab, 6 cycles every 3 weeks, followed by surgery. Crossover to additional preoperative therapy was allowed in the setting of inadequate response. There was mandatory tissue collection at baseline, 3 weeks later at cycle 2, day 1, and at end of treatment surgery. Trial objectives, which are secondary and exploratory for Arm C, include 1, to evaluate PATCR with the combination, and 2, to evaluate change in stromal TILs between baseline and cycle 2 at 3 weeks. PCR rate is estimated and reported with 2-sided exact 90% confidence intervals in this exploratory cohort. 18 patients were enrolled into Arm C. Median age was 41. Many or most had stage 2 disease. 5 patients had BRCA1 mutation. 13 patients had BRCA2 mutation. All 18 patients have completed protocol therapy through surgery, with 2 requiring crossover therapy before surgery. 83% completed 6 cycles of niraparib, mean number of cycles received 5.5. 61% completed 6 cycles of dostarlimab, with mean number of cycles received 4.8. Here are the results from Arm C. 3 patients, or 16.7%, achieved a pathologic complete response with 18 weeks of non-chemotherapy targeted treatment. When considering RCB, the rate was 44.4% for RCB0 or RCB1, a near PATCR. Toxicities were as expected for these agents, most commonly rash, LFT abnormality, and nausea. 12 patients had paired samples evaluable for TILs. Exposure to therapy led to an 11.9% numeric increase in TILs. Here are some examples. Here's one patient with baseline TILs 1% increased to 20%. A more dramatic example, 30% increased to 90%. Of note related to the prior discussion, these were all scored by a single pathologist. 17 patients had evaluable baseline TILs. When assessed as a continuous variable, higher TILs at baseline was associated with PATCR with a p-value 0.04 and trended towards association with an RCB01 response. Analyses of additional biomarkers, including PD-L1, ER percentage, and genomic profiling, are underway. In conclusion, in this small exploratory cohort of ER-positive germline mutated breast cancer, preoperative PARP inhibitor and PD-1 inhibitor exposure resulted in a PCR rate of 16.7% and an RCB01 rate of 44.4%. Exposure to therapy led to a modest increase in TILs, and increased baseline TILs were associated with pathologic response at surgery. Given the activity of preoperative PD-1 inhibition for ER-positive breast cancer, additional evaluation of targeted non-chemotherapy approaches is of great interest. Furthermore, additional exploration of the immunosuppressive components of the tumor microenvironment may help fully realize the impact of combining immunologic approaches with PARP inhibition. Further data from the triple-negative cohort of this study are awaited. I very much would like to thank BCRF and Susan G. Komen for their support of the TBCRC, and most importantly, all the patients who have participated in the TBCRC 056 clinical trial. Thank you so much.
Thank you, Dr. Mayer. On point. You can ask questions by walking to the microphones or through the Slido. If nobody's at the microphones yet, I'm going to ask a question. So looking at that data, there were quite some patients in there with stage 1, and it's very impressive to see the TIL response. The PCR patients, did they rather come from that group of small tumor patients, or did you see some of these patients that had a really, really good response as we think, okay, that's the treatment, because then you would have a good rationale to think that there are some patients where you have this synergistic effect, maybe setting the stage for a combination, for a possible combination, if Keynote 756 leads to an approval in that situation. So what do you think about that?
It's a very good observation that the patient population in this study trended towards smaller sized tumors. This reflects that many of the patients enrolled in the study had a known germline mutation before they were diagnosed with breast cancer, and their cancers were diagnosed on MRI screening. At this time in this small cohort, we don't have enough numbers to be able to make an assessment between tumor size and the likelihood of response. As I mentioned, we have a larger number of patients in this study with triple-negative breast cancer, and we hope to be able to address questions like that with the larger cohort.
Thanks. There's a question on microphone number 6.
Erica, Andrew Tutt, London. Thank you. Fantastic study. A lot of patients with BRCA2 mutations, as you might anticipate in ER-positive breast cancer. In advanced disease, resistance to PARP inhibitors is often through reversion mutation, particularly in BRCA2 carriers. Do you see that in your high RCB residual disease population? Have you looked for that yet?
Thank you so much for your question, and that's a very great point. We're fortunate that we've collected a large amount of tissue as part of the mandatory biopsies in this situation, and work is underway to look for predictors of resistance such as BRCA reversion. So we'll look for that and report on it.
Thank you. Thank you, Erica. I think we move on. So the second presentation is by Maria Vittoria Dieci from the University of Padua in Italy. We've learned about the results of the A-BRAVE study earlier, and now I'm very curious to learn about PD-L1 tumor infiltrating lymphocytes and the RCB classification in the context of the A-BRAVE study. Thank you.
Thank you. Thank you for the opportunity to present this first biomarker analysis of the A-BRAVE trial. These are my disclosures. So A-BRAVE is a phase 3 randomized trial testing the efficacy of adjuvant anti-PD-L1 avelumab for patients with higher risk triple-negative breast cancer. 466 patients were included and randomized to receive 1 year of avelumab as compared to observation after the conclusion of standard treatment with curative intent. 18% of patients had received prior primary surgery followed by adjuvant chemotherapy and were considered as high risk, qualifying for enrollment in the study according to pathological stage. 82% of patients had received prior neoadjuvant chemotherapy without achieving a pathological complete response. The co-primary endpoints of the trial were disease-free survival in the intention to treat and in the post-neoadjuvant population. Although there was a numerical improvement in both these endpoints with avelumab, this did not reach statistical significance. However, both overall survival and distant disease-free survival were significantly improved with avelumab. Today, we present the analysis on the prognostic and predictive role of 3 biomarkers. PD-L1 was evaluated in the intention to treat population on treatment-naive tumor samples. A research use only immunohistochemical assay and a digital pathology workflow were used to score the percentage of positive stromal cells over the total of stromal cells, and a cutoff of 21% was used, as this was identified by our group as the cutoff with the best prognostic performance in triple-negative breast cancer with this assay in a parallel cohort. TILs and residual cancer burden were evaluated in the post-neoadjuvant population. TILs were assessed on post-neoadjuvant treatment surgical samples, and RCB was locally assessed. Survival outcomes were disease-free survival, distant disease-free survival, and overall survival. Higher levels of PD-L1 expression were associated with improved outcome, and this was consistent across the three main survival endpoints, as well as when PD-L1 was considered as a continuous variable or a categorical variable, as you can see by the Kaplan-Meier curves shown here according to the 21% cutoff. Here you have the impact of avelumab as compared to control in categories of patients defined according to PD-L1 expression levels at the 21% cutoff. An improvement in survival endpoints with avelumab was evident for patients in the PD-L1 low category, and as this was not the case for patients in the PD-L1 high cohort. However, please consider that in the PD-L1 high group, the number of patients and the number of events were very small, and the interaction test was not significant. Moving to the post-neoadjuvant population, as expected, RCB was highly prognostic, as you can see here by the Kaplan-Meier curves comparing RCB 1 and 2 categories to RCB 3. And we also confirmed that TILs on residual disease as highly prognostic in this setting. Kaplan-Meier curves show survival estimates according to the 10% cutoff. And we also consider TILs as a continuous variable, and we identified for each 5% increment in TILs, a 10% reduction in the risk of a disease-free, distant disease-free, or overall survival event. And this prognostic role was independent from RCB in a bivariate Cox model. Here you have the effect of avelumab as compared to control in RCB-defined patient categories, RCB 1 and 2, and RCB 3. Although there was at least a numerical improvement in survival outcomes with avelumab maintained in both categories, the magnitude of benefit was larger in the RCB 3 group, with a borderline test for interaction for distant disease-free survival. And here you have the impact of avelumab as compared to control in categories of patients defined according to TILs at the 10% cutoff. An improvement in survival endpoints was evident for patients in the low TIL category and was far less evident for patients in the high TIL category with a non-significant interaction test. So in conclusion, baseline pretreatment PD-L1 expression is prognostic in TNBC patients at high risk of relapse. For patients with residual disease after neoadjuvant chemotherapy, both RCB and TILs on the surgical sample are independently associated with survival. Efficacy of adjuvant avelumab for high-risk triple-negative breast cancer patients was more evident for biomarker-defined subgroups at poor prognosis, meaning low PD-L1 at baseline in intention-to-treat population, and RCB3 or low TILs on residual disease in the post-neoadjuvant population. With that, I would like to thank all patients and their families, centers and investigators providing samples for biomarker analysis, Merck, who supported the BRAVE trial, and all other our funding sources. Thank you.
Wonderful. Microphones for questions, or use the Slido app. Let me just make one comment. It was just in the last session where we learned about the disappointment of the Padua study that people requested exactly that data that you just presented to differentiate the effect of the chemotherapy versus the effect of the immune therapy with the current markers. So is this one IO approved in the early breast cancer setting? So what do you think will be your vision for using biomarkers to select for or against chemotherapy, or to select for or against immuno-oncology therapy? Is it these three markers, or what would be the next steps? You know, what would it need to develop a test to inform for or against EO therapy?
Yes, thank you for the question. So just to add a piece of information to what I just presented, we are missing now data on the pre-treatment baseline TILs in our BRAVE trial. Analyses are ongoing, and we just saw in the GEPARDUS that high TILs at baseline seems to predict for the efficacy of atezolizumab added to neoadjuvant chemotherapy. So here, probably on the TILs on the residual disease are selecting patients at poorer prognosis that derive the benefit from avelumab. But this may seem counterintuitive as compared to the data from the GEPARDUS. However, probably TILs at baseline may tell a different story in terms of prediction. So I really think we need TIL at baseline in all these trials and pull them together and see whether this could be an easy, a cheap, affordable marker, universally, globally available to stratify patients for immunotherapy.
I think there's a very rapid question on microphone 6. It has to be a fire answer.
Rapid question, Vogel, New York. So I'm puzzled by low TILs being prognostic, and maybe those TILs that are there are effete, and the avelumab works because the patient needs an immune response that he's not getting, or she's not getting. Does that make sense to you?
So your question is about the level of TILs and the efficacy of avelumab.
Right, avelumab worked when there were low TILs in the residual cancer burden. So if there were low TILs, then there was no immune response, and maybe avelumab could make an immune response better.
Yes, I agree. Just to clarify that in our low TIL category, the majority of patients had some TILs, so had something like about 5% of TILs. This was the most represented category within the low TIL, so probably the immunotherapy boosts something that chemotherapy was not able to make effective. But again, I think we should look at TILs at baseline, and we will look at the dynamic of TILs from baseline to post-treatment to really see whether this could help teasing out those patients that really need immunotherapy.
Thank you. Thank you very much. The next speaker will be Olivier Trédan from the Centre Lèon Bèrard, and they will inform us about their study of nivolumab and ipilimumab versus capecitabine in post-neoadjuvant setting in triple-negative breast cancer patients. Thank you.
Thank you very much. I would like to thank the organizing committee for choosing our abstract in this rapid fire session. This is my disclosure. So the residual cancer burden classes are routinely used to characterize patients after neoadjuvant chemotherapy. The RCB index score where 0 is the pathological complete response, and 1, 2, or 3 corresponding to minimal, moderate, or extensive residual disease, is correlated with the event-free survival. There is a very much lower survival probability in the RCB2 and 3 groups compared to the RCB0 group of patients. The BREAST-IMMUNE-03 study was designed in 2017, before the approval of the checkpoint inhibitor pembrolizumab that is currently combined with neoadjuvant chemotherapy in accordance with the KEYNOTE-522 data. Capecitabine is so the only postoperative chemotherapy treatment option for non-PCR patients. The BREAST-IMMUNE-03 study was an open-label phase 2 collaborative effort enrolling triple-negative breast cancer patients who went for surgery after neoadjuvant chemotherapy without immunotherapy and had RCB2 or RCB3 score. The study design was a 1-to-1 randomization. The plan was to enroll 114 patients. Patients were randomized to receive either the combination of nivolumab every 3 weeks for 8 cycles, plus ipilimumab every 6 weeks for 4 cycles, or the capecitabine chemotherapy alone for 6 months. The primary endpoint was invasive disease-free survival. Secondary endpoint included overall survival, local regional recurrence rate, distant recurrence-free survival, safety, health-related quality of life. There was 80% power for the log rank test to detect an improvement in IDFS at 2 years from 60 to 80% with an alpha of 0.5. 123 patients were screened, and when 95 patients were included, an independent data monitoring committee reviewed the study data. The recommendation was to discontinue enrollment due to 4 events related to myocardial enzyme increase. Importantly, none of these biological abnormalities was associated with clinically relevant left ventricular dysfunction. Here is the detail of the population enrolled. A total of 45 patients were treated with the combination of nivolumab plus ipilimumab, and 50 patients were treated with capecitabine. The median age was 47 years. 50% of patients had node-positive disease. The majority of patients had grade 3 tumors. 60% of patients had RCB2 score, and 40% had RCB3 score. The median follow-up was 34.3 months. The bottom line is that the combination of nivolumab plus ipilimumab in this high-risk triple-negative breast cancer population did not confer any benefits compared to capecitabine alone. There was no improvement in the IDFS. The 3-year IDFS was 62% in the immunotherapy arm and 60% in the capecitabine arm. The 3-year overall survival was 75% in the immunotherapy arm and 73% in the capecitabine arm. The 3-year distant recurrence-free survival was 71% in the immunotherapy arm and 68% in the capecitabine arm. In terms of toxicity, in the NIVO+IPI arm, 49% of patients had reported grade 3 or more immune-related adverse events. 17 patients had discontinued immunotherapy due to adverse events compared to only 7 patients in the capecitabine arm. As expected for capecitabine, there was an increased incidence of head and foot syndrome and hematological toxicities. So in conclusion, there is no statistically significant difference in terms of outcome for the immunotherapy combination compared to capecitabine in this postoperative setting after neoadjuvant chemotherapy without immunotherapy. Immune-related adverse events may limit the use of this nivolumab plus ipilimumab combination in this setting. The recent standard use of neoadjuvant pembrolizumab for stage 2 and 3 triple-negative breast cancer patients limits the interpretation of this breast immune 03 study. And translational research are ongoing. And with that, I want to thank the patient and their family, all the key investigators, the study staff, and Bristol Myers Squibb for their support. Thank you for your attention.
Thank you, Dr. Trédan. Any questions from the audience? Go to the microphone or post it online. Just a quick question. You listed the adverse events that were larger than 10%. Were there any other clinically meaningful adverse events in the immuno-oncology side effect profile that you've seen with the combination? Do you see any role of the double checkpoint inhibition in the future in breast cancer? Because we're not used to the double checkpoint inhibition if you only treat breast cancer. Do you see any way forward for this double combination?
My feeling is that with the double immune checkpoint inhibitor treatment, there were more side effects, especially more symptomatic side effects. We do see some fatigue, pneumonitis, and myocardial dysfunction for other clinical trials with double immune checkpoint inhibitors. And maybe for young patients with breast cancer, the majority of them are cured with the chemotherapy, and I don't think the double checkpoint inhibitor may have a place in this setting.
Thank you, Dr. Trédan. We have to move on. It's a rapid fire session. So the next presentation is by Dr. Vicente Valero from the MD Anderson Cancer Center, and we're going to be informed about the NRG-BR004 study where we turn now to immuno-oncology therapy in the HER2 positive setting. Vicente, please.
I would like to thank the steering committee of the San Antonio Breast Cancer meeting to select our abstract for presentation. Here is my disclosure information. So here is the background and rationale behind BR004. Cleopatra is a trial that established the role of THP as a standard of care in first-line HER2-positive metastatic breast cancer with a significant improvement in progression-free survival and substantial improvement in median overall survival with the addition of pertuzumab to the regimen. In preclinical studies, an anti-PD-L1 monoclonal antibody significantly improved the activity of the anti-HER2 antibody. BR004 was designed to determine if the addition of PD-L1 inhibitor, atezolizumab, to standard THP could improve oncological outcomes with acceptable safety profile. Here is the study design. This study was designed to enroll 600 patients within 24 months. It was activated in March 12, 2019. Patients were eligible if they have a central confirmation of HER2. Also, there was a central confirmation of ER, PR, as well as a PD-L1. Patients need to have measurable disease, no prior therapy for metastatic disease, and good organ function. You can see the stratification on the slide. Patients were randomized to receive THP plus placebo, as listed in the slide, including the taxane or paclitaxel or docetaxel, and the experimental arm will have THP plus atezolizumab. In late April 2022, it was noticed an imbalance of deaths, sex, on the treatment and the treatment was identified. Therefore, after discussion with the committee, independent committee, the accrual was permanently discontinued in May 20, 2022. The protocol was amended to allow us to capture the progression-free survival and overall survival up to April 2024. The median follow-up of PFS on study is 31.9 months, and for overall survival, 35.9 months. This is the consort diagram. 91 patients were allocated to the placebo arm with THP, and 96 to the atezolizumab arm. You can see the patient characteristics. About 20% of the patients were less than 40, 30% of the patients were older than 60, the majority were female and white. About 1/3 of the patients' tumors didn't express estrogen receptor, and 75% of the patients' tumors didn't express PD-L1. As you can see in this slide, 80% of the patients did not receive neoadjuvant or adjuvant trastuzumab. The great majority of these patients that were presented with stage 4 de novo. You can see the number of 6-week cycles. The cycles were 6 weeks rather than 3 weeks. And you can see there was quite balance between the control arm and the atezolizumab arm. The same thing is for the number of taxane-based duration during the trial. You can see in this slide the overall adverse events. So for the patients in general, for patients grade 2, 3, or 4 toxicities, there was no clinical meaningful difference, with the exception you can notice in the slide. There was a little higher incidence of diarrhea, nausea, and obviously it was a higher incidence of hypothyroidism. We had 6 deaths in this, on the treatment arm with atezolizumab, as you can see in the slide and in the first bar. Here is briefly the treatment-related deaths. I'm not going to go over that because of the limitation of time, but about 3 of them were clearly related to the treatment, 1 potentially related, 1 patient had a very rapid progression, and another patient has some cardiac dysfunction that potentially was exacerbated by the treatment. Progression-free survival is depicted in the slide. At the 31.9 months median follow-up, the progression-free survival for the control arm is 22 months, and for the atezolizumab arm, 38 months. Overall survival is data is immature, as you can see in the slide. You can see the number of deaths up to this to the analysis: 17 in the placebo arm and 14 in the atezolizumab, including the ones treatment-related deaths. In summary, due to the imbalance of deaths on the atezolizumab arm and the persistent slow accrual through the trial, BR004 was closed for early accrual in April 2022. Atezolizumab and placebo was stopped, patients were unblind, and therapy was continuous as the investigated discretion. The patient was amended, and that way we can capture the data that I'm presenting today. In general, there was no clinical significant difference in grade 2, 3, or 4 toxicities between the arms. With a median follow-up of 31.9 months for PFS, superiority to the atezolizumab relatively to the placebo could not be claimed with the small sample size. Overall survival, as I mentioned, is immature. Although the results of the BR004 don't support adding atezolizumab to THP, the findings support the potential role of checkpoint inhibitors in patients with HER2-positive metastatic breast cancer, perhaps in combination with antibody-drug conjugates. This study was sponsored by the National Cancer Institute and also by Genentech. I would like to thank the patients who participate in the trial, as well as their families, and importantly, the investigators and their research teams that participate in the sites, and the participating sites. Thank you for your attention.
Thank you for the nice presentation. There's a question waiting at microphone 1.
Murray, Adelaide, Australia. Were the patients who died receiving paclitaxel or docetaxel?
For receiving the paclitaxel. Can you repeat the question?
I think you could. There was a choice of paclitaxel or docetaxel. Which were those who died receiving?
So the protocol was amended to include patients with the 2 taxanes, and you can have the choice to do weekly paclitaxel or every 3 weeks docetaxel. So we make an amendment to try to incorporate different changes to see if we can improve the accrual. For instance, they can receive 1 cycle of pertuzumab, trastuzumab before they initiate the therapy, awaiting for the results of the HER2 central confirmation. And obviously, the patient, we look in small sample size, but right now we are trying to look at different difference between this small sample size to see if we can get some additional information.
No, but my question is, which chemotherapy were those who died receiving?
There was 2 patients that they were in the docetaxel arm, and 1 patient was in the paclitaxel arm. I think there was kind of 2 and 4. 2 in the I don't have it in the top of my head right now.
Thank you very much. I'm sorry, time's up. But the next presentation will also be about HER2-targeted therapy and immune therapy, in that case with pembrolizumab, a phase 2 study presented by Heather MacArthur from the University of Texas Southwestern Medical Center in Dallas. Heather, please.
Thank you. First, I'd like to thank the program committee and the organizers for selecting this abstract for presentation. These are my disclosures. So by way of background, immune checkpoint inhibition is synergistic with HER2-directed therapy in preclinical models. Clinically, pembrolizumab-mediated immune checkpoint inhibition plus HER2-directed therapy with trastuzumab was safe and demonstrated modest activity in trastuzumab-resistant HER2-positive metastatic breast cancer. Because immune checkpoint inhibition may confer more robust activity when administered earlier in the course of the disease, pembro and trastuzumab administered in the curative intent, treatment-naive neoadjuvant setting may mitigate the need for polychemotherapy, may overcome the need for dual HER2 blockade with pertuzumab, may improve pathologic complete response rates, and may confer lifelong tumor-specific immunity and better cure rates. NeoHIP is a phase 2 multi-center investigator-initiated study of paclitaxel with trastuzumab or pertuzumab or THP versus THP plus pembro versus TH with pembro. Here's the study design. Patients with stage 2 or 3 HER2-positive disease were randomized 1:1:1 to receive either THP for 4 cycles or THP plus pembrolizumab for 4 cycles or TH with pembrolizumab for 4 cycles. The stratification factors were node status and hormone receptor status, and the primary endpoint for this study was pathologic complete response. Notably, enrollment to Arm C was terminated after 22 patients were enrolled and underwent surgery due to a pre-specified interim analysis. It's also worth noting that additional chemotherapy was permitted before surgery if residual disease was biopsy proven after the intervention. These are the study characteristics. The median age was 52. More than half of the patients were white or non-Hispanic, although notably there was considerable diversity in this patient population, which reflects the sites that were selected to participate in the study. More than 80% of patients had T1 or T2 disease, approximately 60% had node-negative disease, and just over 60% had hormone receptor-positive disease. Here's a summary of the study treatment analysis populations. There were 58 patients evaluable for PCR evaluation and safety in the THP arm and 58 in the THP pembro arm. It's worth noting that 4 patients in the THP arm received additional chemotherapy before surgery due to biopsy-proven disease, and there were 3 patients in the THP pembro arm who also received preoperative chemotherapy due to biopsy-proven residual disease. Here are the results for the primary endpoint of pathologic complete response. The control arm, THP, had a pathologic complete response rate of 48.3%, which is comparable to the THP arm of the NeoSphere study. The addition of pembrolizumab to THP improved pathologic complete response by 18.9%, and the benefit in favor of pembrolizumab was observed regardless of the definition for PCR that was applied. Here are the adverse events, and you can see that the any grade rate was very similar between arms A and arm B, with approximately 20% grade 3 to 5 adverse events in the arm A and B, consistent with the known profile of the backbone. With respect to immune-related adverse events, there were immune-related adverse events in greater than or equal to 2 patients or greater than or equal to grade 3 reported during the study intervention, only reported in arm B, grade 3 to 5, 5.2%, but no events leading to death or discontinuation of drug. Most of those immune-related adverse events were rash, although there was 1 pneumonitis event. So in conclusion, the addition of pembrolizumab-mediated immune checkpoint inhibition was safe and improved pathologic complete response beyond standard of care THP, but it did not mitigate the need for dual HER2 blockade. The PCR rate in the TH pembro arm was only 25%, and that's why that arm was discontinued early. To our knowledge, this is the first study to demonstrate a clinically meaningful benefit with immune checkpoint inhibition and dual HER2-directed therapy in the curative intent HER2-positive breast cancer setting. Early administration of this combination may eliminate the need for polychemotherapy, minimize toxicity, and improve long-term outcomes for patients with early-stage HER2-positive breast cancer. Event-free survival, subset, and correlative analyses are currently underway. With that, I would like to thank all participating patients and their family. A huge thanks to the NeoHIP investigators and their research staff, and significant gratitude for the funding. Investigator-initiated trials are increasingly difficult to undertake, so I'd very much like to thank the Breast Cancer Research Foundation and Merck for the support of this effort. Thank you.
Do we have some rapid questions? I'm just passing by the microphone over there, okay. So I have a question. Maybe I didn't see it, but was there like a formal interaction test for the differences between the two groups where you saw that difference? And are you aware of any other descriptions of biomarkers, that would help to understand difference between ethnic groups and immune therapy?
No interaction test, and the biomarker analyses are underway. So we'll look at conventional biomarkers, including TILs and PD-L1, but we're also doing some spatial omics and RNA sequencing to better understand predictors of response, potentially.
Thank you. We have to move on. It's rapid. So, these silicone transplant films that you can use as a dressing for fragile skins. I love those. So the next presentation by Kimberly Corbin will talk about those and the reduction of radiation dermatitis in their Allianz 822-1803 study. There you go.
Thank you very much. On behalf of my co-authors and the entire study team, I'd like to thank the organizers for the opportunity to be here to present the results of our Mepitel film trial. I have no relevant disclosures or financial conflicts of interest. For background, radiation dermatitis is a common source of morbidity for patients undergoing breast radiation. When it's significant, it can lead to treatment delay, patient discomfort, and reduced quality of life. Patients who are undergoing post-mastectomy radiation therapy are at higher risk for significant radiation dermatitis compared with patients undergoing more limited forms of radiation. We typically see radiation dermatitis appear around the middle part of treatment and peak around the end of treatment or in the 1 to 2 weeks after. Despite how common it is, there is no universal consensus for radiation dermatitis prophylaxis or management. Common preventive and standard of care management approaches are listed there, but typically include topical aqueous creams and steroids. Mepitel film is a silicone-based dressing originally designed for wound care. Several years ago, around the time of study design, a few institutions, including my own, began to report on the use of Mepitel film for radiation dermatitis reduction. This study is the phase 3 randomized clinical trial comparing Mepitel film with institutional standard of care in the setting of radiation dermatitis. It was a 2-to-1 randomization in favor of Mepitel film. Of note, for institutional standard of care, we allowed for any non-film-based approach. We stratified based on a number of factors, including the presence or absence of breast reconstruction, patient BMI, radiation parameters, including the use of boost and bolus. We accrued across 25 sites and recruited patients undergoing conventionally fractionated photon-based post-mastectomy radiation therapy. Our primary endpoint was the severity of radiation dermatitis as measured by the patient-completed component of a radiation-induced skin reaction scale called the RISRAS scale. We collected this at baseline and weekly during radiation therapy, as well as in the 1 to 2 weeks after treatment and at 3 months. We had a number of secondary endpoints, a few of which I'll report today. These include the provider component weekly RISRAS score, the combined RISRAS score, and a number of acute adverse events solicited from CTCAE. Our hypothesis was that Mepitel film would reduce the severity of radiation dermatitis as compared to institutional standard of care. The RISRAS scales are shown here. The upper table represents the patient component. It assesses the presence of tenderness, discomfort, pain, itch, burning, and the degree to which day-to-day activities have been affected by the skin reaction. The provider component is shown below. It assesses the presence of erythema, dry desquamation, moist desquamation, or necrosis. We registered 216 patients, with 73 assigned to the standard of care arm and 143 assigned to the Mepitel film arm. Of note, 8 patients on the standard of care arm withdrew consent prior to beginning protocol treatment, leaving 65 patients evaluable for the primary endpoint in the standard of care arm, compared to 143 on the Mepitel film arm. Patient characteristics are displayed in this table. The median patient age was 53. The BMI distribution is as displayed. About 2/3 of patients had breast reconstruction, and about 1/3 were planned with bolus, and 20% were planned to undergo a boost as a component of their radiation treatment. In terms of our primary outcome, we had very high RISRAS completion rates at each time point and collected a median of 8 time points per patient. As you can see, Mepitel film significantly reduced radiation dermatitis by an area under the curve of 11.2. In a pre-planned analysis, we also observed a time effect, showing that RIS-RAS scores were lower with Mepitel film during weeks 4, 5, 6, and in the 1 to 2 weeks following completion of radiation therapy. This very nicely aligns with when we typically see the peak effect of radiation dermatitis. And this positive effect held across our stratification factors. In terms of our secondary endpoints, the combined risk-stress score was also significantly lower with Mepitel film, with a difference in area under the curve of 16.1. For our solicited adverse events, we saw a significant reduction in grade 2 or 3 radiation dermatitis with the use of Mepitel film from 44.6% to 25%. We observed no difference in acute ichneiform rash, pruritus, or skin infection. There were no grade 4 or 5 adverse events, and there is no difference in oncologic outcomes. In conclusion, Mepitel film significantly reduced radiation dermatitis as compared to institutional standard of care. These findings support the use of Mepitel film as a new standard of care option for patients undergoing radiation to prevent or reduce radiation dermatitis. We have ongoing follow-up for additional secondary endpoints, including a blinded panel for photographic review and radiation dose parameters at the skin correlating with skin toxicity. We're also following this cohort long-term to assess late toxicity and reconstructive outcomes. And with that, I'd like to thank the many sites, collaborators, research personnel, the NCI, the Alliance Symptom Intervention Committee, and of course the patients. And I'd also like to give a special thanks to Charles Laprinzi, whose mentorship and support was instrumental in the success of this trial.
Thank you very much. I'm wondering whether Dr. Vogel has the same question on microphone 6 that I have in my head.
So I didn't catch how you do this. Do you put this film on before the radiation and leave it on for 6 weeks? Do you put the film on and change it every day, every 3 days, every week? And if you put it on in the beginning, how do you justify doing that when the skin is perfectly normal?
Yeah, I think these are great questions. I hope what I've just shown is that there's a prophylactic approach with starting the film before we develop a skin reaction, and then that does reduce the peak skin reaction. But in terms of logistics, the film is placed before radiation therapy begins, and it's typically changed about every 1 to 2 weeks. So as part of the protocol, we had nurses or protocol personnel at each of the locations trained in how to place the film.
Thank you.
I have one more question. I love it when you can, with simple measures, help the patients with the side effects. I love it. So my immediate question is, but you had it on this slide with a long-term follow-up, but you must have some experience, you know, the skin pigmentation, sensitivity problems as long-term issues, telangiectasia and stuff like that. Do you have any idea or suspicion or gut feeling whether this will help with that too, or what's your take on that?
Yeah, I mean, I think we hope that it will help with that. Our own institution has been using the film for some time, and we've seen some promising long-term results in terms of cosmetic results that we think may be attributable to reduced acute skin toxicity, but time will tell for the study.
Thank you very much. We're almost on time, so we're moving to the last presentation. Dr. Ray from the University of Birmingham from the United Kingdom will talk about the ROSCO study, Response to Optimal Selection of Neoadjuvant Chemotherapy in Operable Breast Cancer, and will involve some chemotherapies. I'm very curious to learn about that.
Thank you. I'd like to thank the organising committee for accepting this abstract for presentation. This is quite a complicated study. You're very tired. I've cut this down to the bare minimum bones. If some of the detail that you want isn't there, come and see me afterwards and I'll be happy to talk it through. But I'm trying to just give you the primary outcome measure information. Okay, so those are my disclosures. So the background to this study was we don't really know who should have what chemotherapy, and we're still debating in this meeting who should have anthracyclines and who shouldn't. And that debate's been going on since anthracyclines started. Some time ago, we identified in a study of CMF versus epirubicin followed by CMF, in a translational search for biomarkers of anthracycline sensitivity, that the centromeric region of chromosome 17, so-called CEP17, that's the test that's done as part of the control for a HER2 FISH test. If you had CEP17 duplication, all the benefit from anthracyclines appeared to be confined to that group, which is a surprising finding, but it was replicated in a meta-analysis. But in addition to the CEP17, it was identified that there was an additional value of adding in topoisomerase 2 deletion or amplification, again measured by a FISH test, and that gave you a dual biomarker that was a potentially very powerful indicator of whether anthracyclines worked or added benefit on top of CMF. So ROSCO is designed to evaluate the ability of this combined biomarker to predict differential sensitivity to neoadjuvant anthracyclines and taxanes. So this biomarker needed to be tested in the anthracycline and taxane era rather than the CMF epirubicin era. So when I say biomarker abnormal, I mean either CEP17 duplicated or topo2 deleted or amplified or any of those two. And that's all assessed by different FISH markers. So this is the ROSCO trial scheme. So patients with T2 or above or node-positive invasive breast cancers who were considered suitable for neoadjuvant chemotherapy were recruited to the study. A key exclusion criteria was patients in whom a pathological complete response is uncommon and not very helpful in terms of prognostic ability. So those are the ER-rich, PR-rich, grade 1-2 tumors that are HER2 negative. So patients recruited were stratified by centrally determined biomarker status, ER-HER2 or nodal status, and then randomly allocated to an anthracycline-containing regimen, epirubicin cyclophosphamide with or without 5-FU according to investigator choice, or docetaxel cyclophosphamide for 4 cycles. Patients then went on to surgery, and the primary outcome here was pathological complete response in terms of no invasive disease found. If there wasn't a PCR, patients were allowed to cross over to the alternative chemotherapy, and there are various other downstream options which I won't discuss. HER2-positive patients received anti-HER2 antibodies, and I'll move on now. So the statistical design for this study was to detect a treatment by biomarker interaction between the treatment and the biomarker. I'm not going to go into this in great detail, but we're expecting around about a 9% difference in PCR for it to be clinically relevant, and we needed 1,024 patients to make this work. So the results of this study I'm going to present very briefly. We recruited 990 patients, of which we have 952 patients evaluable for the primary endpoint. Various people fallen off the log on the way before we could get to the primary endpoint. The groups were well balanced for baseline characteristics. 60% patients were ER positive, 50% HER2 positive, 25% triple negative, and about 50% node positive. So quite a high-risk population. Overall, the biomarker was abnormal in 76% of cases. That was higher than we expected, and probably because we excluded those low-grade ER-positive tumors. And there were quite a lot of HER2-positive patients in there. Now, I'm not going to talk about toxicity. That was consistent with the expectations of the regimens, which are well known to all of us. There was one toxic death in the docetaxel arm. So I'm now going to move on and show you the pathological complete response rate. And we see there that the response rate to FEC or TC overall was very similar, 25 versus 28%. And if we then divide that by biomarker, we see that in the TC arm on my right, there's no difference between the biomarker normal or abnormal result. And in the EC FEC arm, there's a difference of 9.3%. Unfortunately, when we do the biomarker by treatment interaction at the 10% level, the p-value doesn't quite reach statistical significance, so we can't claim success from this trial. But I would point out that we have got a 9% absolute delta on the anthracycline arm comparing the normal and abnormal. So there is potentially some utility in this. So my conclusions are that biomarker abnormalities associated with an increase in PCR to neoadjuvant epirubicin-based chemotherapy with a difference of 9.3%. It has no effect on PCR to neoadjuvant docetaxel-based chemotherapy. Statistical testing at a 10% level didn't reach significance, but is potentially impacted by the lower recruitment than planned. This study was killed by COVID. We stopped recruiting, and most centers didn't recover. So I think the biomarker status might be helpful in refining clinical decisions where the inclusion or omission of anthracyclines is uncertain, and we really do need to do further research on candidate biomarkers of differential chemosensitivity, and I think that's got the strong potential to aid optimal chemotherapy selection in early breast cancer. So thanks very much, everybody, particularly the patients, and I'm sorry I've overrun.
We have 1 minute, so be quick to run to the microphones. Want to run to the break? I have one question. So we learned from some previous studies, for example, BCRG 05 and 6, that there were basically 0 TOP2 amplifications in HER2-negative patients. Did you make no TOP2 amplifications in HER2-negative patients? Did you make the same experience in that trial?
No, we found them, and the number of patients who were TOP2 amplified was about 10%, and about 5% were deleted. And I didn't see a difference between the HER2 positive and negative.
It's a fascinating biomarker, needs more exploration. Thank you very much, Dr. Ray. So we are on time. We can let you go to your well-earned break. Have a very good rest of the San Antonio Breast Cancer Symposium. Thank you very much.